Hello, this is Max Knight, a first-year Doctorate of Athletic Training student at Indiana State University, and this presentation is about Maitland and Mulligan manual therapy techniques, and we'll get started. So the first technique we'll go over is the Maitland manual therapy technique. Basically, with this technique, we're looking for a loss of range of motion in a joint to reduce pain and restore joints range of motion by the use of passive movements. And again, this is to hopefully the intent is to decrease pain, increase range of motion, inhibit any muscle guarding or muscle spasming, and also for joint lubrication to kind of influence more fluid in that joint to get a smoother glide when moving. So pretty big rule with this type of therapy is convex and concave rule. With the convex rule, the convex joint slides in the opposite direction as the bone movement. So a classic example of this is the humerus moving into abduction as the humeral head rolls anteriorly but also slides inferiorly. The concave rule is where the concave joint slides in the same direction as the bone movement. And a really classic example for this is the tibia moving into extension. So we have two terms here, osteokinematics and arthrokinematics. Osteokinematics is also known as physiological joint movement. And this basically is the movement of bones that make up a limb that are operated voluntarily by active or passive motion around the joint. Arthrokinematics is the movement of the joint surfaces that will not move voluntarily or independently. So we got to think of joint play. So the next few points are pretty important to the relationship of both osteo and arthrokinematics. Accessory motion. This is needed for full range of motion. If this is restricted, then it also restricts osteokinematic movement. It's component motion. So if there's restriction of the rotation of the clavicle with shoulder abduction may be limited. It's kind of like little bits and pieces that make up the whole thing. And if there's a cog in the wheel, then things are going to run as smoothly as they could be. So with Maitland, there's graded oscillations. So with that, there's 5 grades. Kind of other parameters we need to think about are there's 1 to 3 oscillations per second. There's 1 to 2 minutes of treatment for pain, and about 20 to 60 seconds for range of motion restriction, kind of like a treatment time there. And then we'll do 1 to 5 reps using the oscillations and time we'll do them. And then lastly, make sure treatments are about 48 hours apart. So going along with the grades here, grade 1 is a small but slow amplitude oscillation to decrease pain. Take note of this. We start parallel to the joint surface at the start of range of motion. Grade 2 is a large but slow amplitude oscillation, again to decrease pain. Again, we're starting parallel to the joint surface within the free range of motion that the patient presents with. Grade 3 is a large but slow amplitude oscillation to increase range of motion, and we'll be doing this from middle to end of range. Grade 4 is a small but slow amplitude oscillation, again to increase range of motion, and we'll be doing this movement up to the end of the allotted joint play. And then grade 5, it's a small but fast amplitude oscillation for joint manipulation. And this should be performed by clinicians who have the proper training or certification required for this. Moving on to Mulligan manual therapy, a pretty big thing with this is it's kind of based off movement with mobilizations, or MWM. So this is a pain-free glide to a joint with problematic movement by the patient to correct any positional faults of the joint. So Mulligan found that there are positional faults within the joint, and that by mobilizing this and moving, we're able to correct this. So he was able to find this by doing the MWM technique on fingers. So there is a pretty well-known acronym within Mulligan's therapy. If you study it, one of the two I mentioned in here is CROCS. So it stands for contraindications, reps, overpressure, communication, knowledge, sustain / skill. So contraindications, mainly for any manual therapy in general, but take note of the underlying pathology, like cancer, rheumatoid arthritis. Take note of bone quality. Make sure there aren't any unstable joints. Assess the blood vessel condition. We don't want to disrupt that. The skin integrity. We don't want the patient to bleed. And then take note of any pain or kind of neural symptoms they may be having with pins and needles or giving away. Reps, less reps are best when treating the spine. Less reps are also best with acute injury with pain or neural instability. More reps are better for chronic injuries. Overpressure, if pain-free overpressure is achieved from a movement with mobilization, then optimal recovery is indicated. So if we're able to do this with no pain, then most likely the patient will be getting better. Up next, there's communication. We need to inform patients of what's going to happen and what we expect to happen. And the patients need to know that they 100% should voice or let us know their symptoms that present before, during, or after treatment. Knowledge. This one's kind of an obvious one. The clinician must have proper knowledge and training of this technique. And then sustain and skill. Make sure that our glide is maintained through the entire movement, and that we have the skill and hand haptics to ensure that there's proper technique. But this comes with experience. Just doing it when you can, when it's indicated, and basically just experience. Another acronym that's pretty prominent with this therapy is PIL. This just stands for pain-free, instant, and long-lasting. So this is what Mulligan's treatments are kind of based off of. They have to be done without pain. The effects have to be instant, and the goal is to be long-lasting. Unlike Maitland, there's no grading system for this method. The practitioner can apply as much force as they want to improve outcomes without creating any pain. So again, if there's any pain doing this, we need to kind of take a step back. So we have sustained natural apophyseal glides, or SNAGs. and this is a glide that's held at end range. And then we have natural apophyseal glides, or NAGs, which are oscillations through a range of motion. So sustained, we hold it, and then without sustained, we have a natural apophyseal glide, which we oscillate. So kind of comparing both of these, both methods have reps and sets particular to specific joints or areas. The indications, contraindications are similar, as both therapies are providing manual therapy techniques. Again, there needs to be communication about any contraindications, presenting symptoms. We need to have proper technique, show the proper technique, and communicating what we're trying to look for as far as what we're doing, the effects, and kind of what comes after with the patient. And also for both of these, which is really important, that therapeutic exercises are recommended in conjunction of treatment for the patient following both techniques. So if you're doing Maitland, you're following that with therapeutic exercise. If you're doing Mulligan, following up with therapeutic exercises. Okay, so kind of at the end of here, our clinical application, there's an article about using manual therapy techniques such as Maitland and Mulligan to resolve cervicogenic dizziness. And so basically in the article, what we know is that cervicogenic dizziness can be caused by cervical degeneration or whiplash. It can lead to disruption of vestibular and visual equilibrium. SNAGs have been shown to reduce cervicogenic dizziness up to 12 weeks, but patient-administered SNAGs outcomes have yet to be looked into. So that's kind of what we know. Mulligan and Maitland manual therapy techniques, they both, using both of these, we're looking to find the effectiveness between self-administered SNAGs, Maitland mobilizations with range of motion exercises, or a placebo effect for subjects suffering from chronic cervicogenic dizziness immediately after and 12 weeks post-treatment. So the design is a 3-arm double-blind study. 3 arms are the placebo, the Mulligan therapy, and the Maitland therapy. There are 86 subjects with cervicogenic dizziness, and they were to receive 2 to 6 therapist-driven treatments over 6 weeks. And the number of treatments were dictated by the therapist's clinical judgment. So starting off with the SNAGs, the patient's head was moved into a symptom-provoking position while the clinician provided a glide to see if flexion or extension could provoke symptoms. Provocation with extension and flexion. If there was, then an anterior glide would be provided at the C2 spinous process. If provocation with rotation, then the C1 transverse vertebrae would have an anterior glide as well. General overpressure is used for 6 reps, and after a second snag was performed, so like a second treatment, the clinician would show the patient how to do a snag on their own with their fingers or strap 6 times once a day. Maitland, so the patients that were assigned to this group, about had an average of 3 sets of 30-second passive joint mobilizations to 3 stiff or painful joints of the C-spine. The grade of them depended on the therapist. And then, again, like the Mulligan or the Snags, a home program was given for neck range of motion after a second treatment. And lastly, there's a placebo group, and basically they were given a laser treatment with a deactivated laser as the laser device's manufacturer discontinued the making of them, and they just deactivated them. So the laser was not functioning. Outcome measures used was the Dizziness Handicap Index, the DHI, and the Global Perceived Effect, the GPE. With the results, both Maitland and Snag groups had a decrease in dizziness intensity and frequency at 12 weeks. There was no difference in the Dizziness Handicap Index between Snags or Maitland mobilizations at 12 weeks. And the GPE found a decrease in all 3 groups at 12 weeks of pain reduction, but more so with the Maitland and Snag treatment. So bottom line, what this article found was that either treatment works. It really kind of depends on the number of treatments, increase of symptoms with treatment, time until the symptoms decrease, and then maintenance. I think it just comes down to what the patient responds to better. So thank you for watching and listening, and have a good day.